Welcome to the American Medical Society for Sports Medicine National Fellow Online Lecture Series. It's sponsored by AMSSM Online Fellows Education Subcommittee, the AMSSM Education Committee, and the AMSSM Fellowship Committees. We serve as an adjunct to your individual program's educational programming. We provide fellows with direct access to educational experiences with experienced AMSSM members and at times invited guest experts in a variety of formats. We assist in CAQ exam preparation. Please mute your device's microphone and turn off your video. Submit questions through the chat function. Include your name and program if you wish. I will ask the questions during the Q&A based on the questions you submit. And after the program, please complete the evaluation, which will be sent at the end of the lecture. Today, we are honored to have Dr. Adam Tenforde speak on bone health. He is an associate professor in the Department of Physical Medicine and Rehabilitation at Harvard Medical School. He is a sports medicine physician at Spaulding Rehabilitation and a member of the Mass General Brigham Healthcare System. Dr. Tenforde is the Director of Shockwave Medicine and Medical Director at the Spaulding National Running Center, one of the only centers in the United States exclusively dedicated to the diagnosis and treatment of running-related injuries. Dr. Tenforde has the unique perspective of being both a doctor and a former professional runner who was an All-American at Stanford University, where he contributed to 3 NCAA national team championships and later qualified for the Olympic trials. He completed medical school, PM&R residency, and a sports fellowship training at Stanford University Medical Center prior to joining the faculty at Spaulding Rehabilitation. Dr. Tenforde's research has focused on understanding modifiable risk factors for stress fractures, tendinopathy, and other running injuries, along with interventions to address those injuries, including use of extracorporeal shockwave. His expertise has been recognized, including serving as a co-chair to develop the first youth running consensus statement, selection to the Collaborative Research Network Youth Sports Specialization Group for the American Medical Society for Sports Medicine, and content expert for the International Olympic Committee Relative Energy Deficiency in Sports updated consensus statement in 2018. He has received multiple grants to support his research, and his work has resulted in over 120 publications and 100 research abstracts. He also serves as course co-director for the annual Harvard Sports Medicine CME meeting and senior editor for PM&R Journal. I did not introduce myself, and I'm almost hesitant to do so after that big intro. My name is Melody Hrubes. I'm in New York City with Rothman Orthopedics New York, and I'm very pleased to serve as moderator and honored that Dr. Tenforde was willing to join us.
Well, thanks for having me, and thank you for the kind introduction. Really appreciate everyone joining to hear this talk on bone health, which is a topic that I feel is really important, not only to understand at the level of a sports fellow, but also something that can be very informative in your future practice of sports medicine. So I have no conflicts of interest to disclose related to this talk. What I plan to do is give you a brief introduction on why we should care about the topic of bone health. And first, to start, bone really plays a critical role in our overall functional status. And this has multiple impacts on physiatry and sports medicine in general. There are consequences that are recognized in disease states resulting from inactivity and due to inactivity that can contribute to low bone mass or age. And in older populations, the terminology of osteopenia, osteoporosis, and increased risk for fractures. A lot of this terminology is very important to understand and to use correctly, especially in younger athletes. And we'll get into some of those specifics during this talk. What we have to understand too is that a lot of the terminology that's been historically used and even screening for impaired bone health has really been limited to postmenopausal women and those with more systemic disease states known to affect bone. We recognize that bone health can really play a huge role though in sports medicine injuries, even in younger individuals. And this is really what leads to interest in this topic and why this is so important for sports medicine practice. So the purposes of my talk are first to discuss the influence of sports participation on bone health, This will help us to understand what are the populations that may be at increased risk for having impaired bone health and some of the injuries that we commonly see associated with that, including bone stress injuries. The next goal will be then to understand those populations at risk, and finally to understand the risk factors and optimal management and prevention strategies around promoting good bone health and reducing the risk for future bone stress injury. So first off, a couple of principles that are very important to understand when we talk about the topic of bone health is understanding two principles that describe the influence of bone loading and how this affects our overall peak skeletal mass. The first is the concept of Wolff's Law, and this really describes how bone is an adaptive structure that responds to mechanical loading. For example, if an astronaut travels to space and comes back to Earth, they will have a reduction in gravitational forces, which can actually lead to a profound amount of bone loss. But then with the appropriate return of gravitational forces and a gradual reintroduction of full weight bearing, much of that bone mass can be regained. In children, there's another concept that I think can be helpful to understand, which is called the muscle bone unit theory. And this describes that aside from trauma, the forces of muscles and tendons acting on bone may lead to peak bone mass development. And this is why participation in youth sports is so critical for lifelong skeletal health. There are a few ways that we can assess bone density, which are important to understand as we talk about how we characterize the differences in sports. The first is dual energy X-ray absorptiometry. If you want to sound like a bone nerd like me, we would more commonly refer to this as DEXA, D-E-X-A. The correct terminology at this point from the International Society of Clinical Densitometry is DEXA, D-X-A. And essentially what DEXA accomplishes is two-dimensional structures of bone mineral density. And those two-dimensional constructs of X-ray are essentially used then to measure bone density, and bone density is a proxy for bone strength. So DEXA scan again is used to define whether someone meets criteria for low bone mass for age or in older populations, osteopenia or osteoporosis. There's a second form of the imaging called high resolution quantitative peripheral computed tomography, or HRP-QCT. And these are actually CT scans that are used to measure three-dimensional constructs of bone geometry. They're typically used in research and really don't have a current role in clinical practice. So when we describe bone mass, there's a few terms you need to be familiar with, and this is something we're always taught with imaging, is we should be able to review our imaging findings and make sure that they're being read correctly. So the term low bone mass for age is defined for the general population by the International Society of Clinical Densitometry as a BMD or a BMC, bone mineral content, Z-score of less than -2.0. A Z-score is a standard deviation, is the number of standard deviations from the mean based on your age, based on your sex, and there are ethnicity normative values. So low bone mass for age in the general population is defined as is a value of -2.0 or less. In contrast, in our sports medicine community, the American College of Sports Medicine and most sports medicine organizations will define low bone mass for age as a BMD or a BMC Z-score of less than -1.0. And this is actually defined for female athletes in weight-bearing sports. However, this has also been proposed based on research by myself and others as being a threshold we should consider for low bone mass for age in male athletes. And the reason for recognizing low bone mass for age is identifying those athletes that may have modifiable risk factors that we can try to address to improve skeletal health and to reduce the risk for future injury. I also think one other key takeaway from this terminology is you see that we don't typically refer to the term osteoporosis in younger adults. I think that's a relatively loaded term and one that really needs to be reserved for individuals that meet very strict clinical criteria, which are beyond the scope of this talk. So why are there differences in thresholds from the American College of Sports Medicine versus the general population? Well, it's been recognized that those athletes who participate in weight-bearing sports tend to have approximately 10% greater bone mass than non-athletes. So that's why that value of less than negative 1.0 is defined as the threshold for low bone mass for age. Now, one of the things that's important to understand too is when are athletes most receptive to changes in sports participation affecting their bone health. And what's been demonstrated is that greater than 90% of peak bone mass tends to be reached by the end of the second decade of life, age 18 for females and age 20 for males. And we also recognize that these gains in bone mass are not evenly spread over that time. In fact, the time around early puberty may be a window of opportunity to emphasize weight-bearing and high-impact exercises. This is because approximately 26% of final bone mass is reached in that two-year window between 11.5 to 13.5 years of age for girls and 13 to 15 years of age for boys. And so it's important to recognize that exercise during puberty, during that time of peak, linear growth, and is going to play a huge role in how strong and potentially fracture resistant these bones will be throughout life. So the question then comes down to if you were asked by an athlete, and I think this is a pretty common clinical situation, what sport should my daughter or son participate in to promote their bone health? Or in the setting of seeing a young athlete who's already starting to think about focusing on one sport at the exclusion of all others, otherwise referred to as youth sports specialization, what are some considerations around other sports that they should continue to incorporate to promote peak bone mass? Well, this is a review that I wrote over a decade ago with Dr. Michael Frederickson at Stanford University. And what we sought to examine was the evidence regarding how sports participation affects bone density and measures of bone strength. What we did was divide sports based on the gravitational forces and the magnitude of loading, along with the different varied directions of loading. So one class of sport we defined as high impact, and that included gymnastics, martial arts such as karate, volleyball, and other jumping sports. A second class was multi-directional impact. So these are other forms of ball sports such as soccer, basketball, racket games, and even speed skating. Repetitive lower impact was defined as distance running. And finally, non-impact sports included the sports of swimming and cycling, which are more endurance-based and really don't involve those repetitive impact ground reaction forces. So what we observed, and it was pretty consistent across the literature, and I would say in the past decade has been substantiated with further research, is that those sports involving high impact and multi-directional loading appeared to enhance bone density and bone geometry. And this was particularly most robust at anatomical locations directly loaded by those sports. Another way of looking at this is there are very specific bony adaptations. If you look at a racket sport player, the racket arm has significantly higher bone strength than the non-dominant racket arm. So again, it's not just doing the sport, but also loading the skeleton in multiple directions and multiple forces that leads to higher peak bone mass. And that bone mass may be more specific to the structures that are being loaded. Now, in contrast, repetitive lower impact loading, such as running, may lead to some modest improvements in bone density and geometry compared to those who don't do an impact sport, such as cycling or swimming, or those that are sedentary. But these results, surprisingly, were not consistent. So essentially, the key finding from this is that runners while a lot in the general community assume that if you're at least doing a sport that involves some degree of ground reaction force, you should have higher bone density and you should be more resistant to injury. And we know from our clinical experience that's not always the case. Now, if we look at non-impact loading sports such as cycling and swimming, what was interesting was that we identified that in many studies, those individuals actually had lower bone density and reduced bone strength compared to those who did no sport. So the answer for this is probably complex, but one way of looking at it is that if you're doing a sport which involves the lack of gravitational forces, muscle activation may not be sufficient to promote stronger bones, and the endurance nature, the long aerobic demands from the sport may also predispose to other behaviors around nutrition, which could also affect bone health, and we'll get into those a little later. Now, the other really key takeaway from sports is there could be also some crossover influences and protection against future fracture. And what's been really interesting to observe is that studies in the military, a lot of the work informed that was subsequently performed by Dr. Fredrickson was actually informed by observations by Dr. Charles Milgram, who's been studying the Israeli military for decades. And what he identified is that in those military recruits who had done 2 or greater years of ball sports, particularly basketball, had up to an 84% reduction in developing a stress fracture when they entered basic training. So again, 2 years or greater of ball sports seemed to prevent, during childhood, seemed to prevent stress fractures in the military. And in contrast, despite the initial assumption that runners and other athletes would potentially be fracture resistant due to better aerobic capacity, those protective measures were not observed. This was subsequently substantiated by Dr. Fredrickson in elite track and field athletes, where he found that participation in ball sports led to approximately 50% reduction in future stress fractures later in life, and that there appeared to be a dose-dependent relationship of every additional year leading to a 13% reduction in the risk for a stress fracture. Interestingly, in that investigation, women who had current menstrual dysfunction did not see benefits of prior ball sports, leading to a reduction in stress fracture risk. Again, arguing that there are multiple factors that influence peak bone mass and response to loading forces. Some of the more recent work that I've done in high school runners and even in middle school runners has also identified approximately an 80% reduction in the risk for stress fractures in high school and middle school runners who had done 2 or more years of soccer or basketball. Again, suggesting we should be promoting sports sampling as opposed to early youth sports specialization, particularly avoiding sports like long distance running until later ages to promote peak bone mass. When we look at why would running be less osteogenic than soccer, we have to look at what are the differences between the sport. Running involves approximately 1,000 loading cycles per mile. It's done in a sagittal plane at 2 to 3 times body weight. Whereas in soccer, there are fewer loading cycles, estimates of between 1,000 to 1,500, but these are done at much higher impact peaks, up to 5 times body weight, and they're done in multiple directions. So there's the cutting, the jumping, and the sudden stopping, which is going to challenge the skeleton in multiple planes of loading and then lead to potentially more fracture resistant bones. So this has been substantiated in multiple studies. I like to point to this work by Dr. Fredrickson, where he looked at bone density in the heel, in the hip, and in the spine. He was looking at male soccer players that were in their early 20s compared to male runners, and sedentary individuals. And note that the soccer players had the highest bone T-scores. And again, with the more recent research, we'd be referring to Z-scores. But those T-scores, again, are another measure of bone strength. And you can see that they're the highest across soccer players. Runners only had higher bone strength or bone density compared to controls in their calcaneus. And that was postulated because up to 90% of us runners strike with our heel. But you see that it's not as robust a participation as soccer in leading to stronger bone gains in the hip or the spine. So one of the takeaways from sports participation is that if you're asked the question, what sport should my daughter or son do at a younger age to promote bone health? My answer would not be to recommend year-round endurance or non-impact sports, because these athletes may have a higher risk for having impaired bone health and would benefit from doing multi-directional, high-impact loading activities to promote improved bone quality. Now, there's a number of additional biological factors. I'm sure most on this call are familiar with this terminology of the female athlete triad. And in the upper green triangle is the interaction of an optimal energy availability status with promoting normal menstrual function and optimal bone health in response to gravitational loads and in the hormonal milieu that promotes appropriate bone remodeling. In the lower left, red triangle represents the low energy availability state that can be present with or without disordered eating. With low energy availability, a female athlete can develop functional hypothalamic amenorrhea. And we'll talk about this in future slides, but that's actually a neuroendocrine disruption. The lack of those cyclic phases of estradiol and progesterone, along with the impaired nutritional substrate, can then lead to severe bone loss and, in the extreme cases, osteoporosis. What's been stated in the 2007 consensus statement and reaffirmed in the 2014 statement is that female athletes can have one or a combination of these factors, and they oftentimes exist on a spectrum of health to disease. So we should be thinking about the fact that female athletes may not be either with optimal energy availability or low energy availability. They can have reduced energy availability, and sometimes this presents with subclinical menstrual disorders such as lighter menstrual periods during more intense training, or periods of time in which they're not having menstrual periods, particularly around heavier volumes of training. And this can lead to lower bone density, which may not also meet the criteria for osteoporosis, which we really reserve for extreme cases. So what we have to recognize too is that the terminology has been expanded to incorporate the female athlete triad into newer terminology, which is used by the International Olympic Committee of relative energy deficiency in sport. I was fortunate to be an invited member to this updated consensus statement in 2018. What's notable in the RED-S model is that the female athlete triad is a recognized interrelationship in the schematic, but what RED-S also refers to is that low energy availability state can have effects on multiple other physiological functions, leading to impairments in immune function, GI motility and absorption, cardiovascular issues, effects on mental health, on growth and development, on hematology such as anemia, on metabolism and other aspects of the endocrine system. And that the RED-S model also acknowledges the low energy availability state has effects on both female and male athletes and those with disability. So the schematic that helps us to understand this model of RED-S or the other terminology of female athlete triad is to understand what happens with low food intake. What this is thought to do is have a downregulation effect on the brain and hypothalamus. So we believe this is neuroendocrine mediated. With low energy availability, we see a reduction in sex hormones. This leads to menstrual dysfunction and a reduction in bone mass in the female athlete. In male athletes, this may lead to lower testosterone and symptoms of hypogonadism. This can also lead to a reduction in growth hormone sensitivity, and this further contributes to loss of muscle and bone mass. Oftentimes, these athletes will report that their metabolism is suppressed, so their solution is I should eat less. What we understand, though, is the low energy availability state is actually suppressing thyroid function, and the solution for that is optimizing energy availability to support normal thyroid function. And finally, we recognize that those athletes in a low energy availability state will have an elevation in stress hormone levels, including cortisol. And what's important to recognize is that puts the athlete in a catabolic state where they're breaking down lean tissue, reducing bone mass, and high cortisol levels can also contribute to menstrual dysfunction. Athletes want to be in an anabolic state. So we have to recognize this low energy availability state is detrimental to recovery and can really contribute to the risk for impaired bone health and multiple other processes that are important for overall health and well-being. In contrast, those athletes with adequate energy availability should have normal menstruation, normal testosterone function in the male athlete, and optimal bone mass, appropriate growth hormone sensitivity, appropriate thyroid function, and normal stress hormone levels that allow for appropriate response to the stress of athletic competition or other daily life stressors. So what we understand about bone health can further be studied, understanding the concept of low energy availability, understanding the different loading forces if we study the sport of running. So this has really been an area of clinical interest and research. And what we've looked at are high school, college athletes, young adults to try to understand some of these risk factors for low bone density. And from these studies, we can help to apply this to other populations of interest. So an earlier study I was fortunate to be part of was during medical school and residency, where we studied 748 high school runners in the San Francisco Bay Area. What we did was have them fill out a baseline questionnaire to identify possible risk factors for stress fracture and low bone density, and also collected DEXA on 136 of these runners. What we observed on the DEXA results was that 14% of girls and 21% of boys met these criteria for having low bone mass. We used slightly different criteria than the American College of Sports Medicine value of less than -1.0. We said less than or equal to -1.0. What we identified is that girls that had a BMI of less than or equal to 17, or the combination of prior fracture and menstrual dysfunction, were much more likely to have low bone mass. And in contrast, for boys, what we identified is actually a similar number for a BMI threshold of 17.5, but also the belief that being thinner leads to faster running performances. Again, possibly a proxy for behaviors around the low energy availability state. We've also looked at Division I collegiate athletes at Stanford University. We were able to characterize female athlete triad risk assessment scoring in 323 athletes participating in 16 sports during the years of 2008 to 2014. What we were essentially getting to do is look at some of these historical, some of these patients and apply the current guidelines to this historical cohort and understand what do these triad risk assessment scores predict for future risk for bone stress injury. And we also were able to look then at differences in bone density by sport type. What we identified in looking at bone density was that those athletes in the sports of basketball, gymnastics, volleyball, and softball had the highest bone mineral density. And not surprisingly, the lowest bone mineral density was observed in endurance sports, including cross country, rowing, swimming and diving, and synchronized swimming. And we identified that on top of that, there are other risk factors outside of sport, as we discussed earlier, that may also contribute to low bone mineral density, including lower BMI values, current oligomenorrhea or amenorrhea, and then particularly looking at the sports of synchronized swimming, swimming and diving, and cross country. When we look at these risk assessment scores, one clinical tool that can be helpful comes from the Female Athlete Triad Coalition statement from 2014. You can take an athlete and look at each of these 6 criteria to try to generate a risk assessment score. The 2 components around low energy availability include whether they display any current or history of dietary restriction, or in the more extreme cases meet DSM-5 criteria for an eating disorder. BMI classifications, people get a moderate risk score if they're between 17.5 to 18.5 BMI, and some other criteria. And then a high risk is that value of 17.5 or less. Delayed menarche, this is a really important concept for sports fellows to understand. This is defined as age of menarche in young women in the United States would be expected before the age of 15. If it's age 15 or greater, that is considered delayed menarche. Between 15 to 16 is considered a moderate risk score, and those with an age of menarche of 16 or older, that's considered high risk. Oligomenorrhea and or amenorrhea, this becomes challenging when we talk to the athlete, but understanding that one of the female athlete vital signs is menstrual history. And again, this is not on any form of hormonal contraception or other hormones known to affect menstrual cycles. If a female athlete has had 9 or more menstrual periods per year, that's considered low risk. If they've had 1 year at any point of 6 to 9 menstrual periods, that's considered moderate risk. And if they've had a history of fewer than 6 menstrual periods in 12 months, that's considered high risk. Low bone density, again, those values between -1 to -2 are moderate risk, and -2 or less would be high risk. And then the number of bone stress injuries, terminologies that athletes more commonly understand are stress reactions, stress fractures. If they've never had one, that you get no points for that. You're moderate risk if you've had 1, and you're high risk if you've had 2, or if you've had an injury in a bone that's considered more trabecular rich, which would be defined as the pelvis, the femoral neck, and I would argue the calcaneus. So these risk scores can then be tabulated to determine if an athlete is considered low risk, moderate risk, or high risk. What we identified is that if you apply these risk assessment categories in adjusting for cross-country participation and age in these Stanford athletes, we found that those that were moderate risk athletes compared to those that were low risk on the Triad scoring had a 2.6-fold increased risk for bone stress injury, and those that were high risk had a 3.8-fold. If you look at cross-country runners as a population, 12.5% of the athletes in the low risk category sustained a bone injury on average a year after that Triad score was calculated, 50% in the moderate risk category, and 71% in the high risk category sustained a bone injury. So again, it was greater than the flip of a coin if you're in an elevated risk category for sustaining a bone injury in within a year of calculating the Triad risk assessment score. So this further highlights the importance of applying a clinical tool such as the Triad risk assessment scoring to identifying athletes that you may have further concern about their risk for future injury. One other takeaway from the study, and this has been substantiated in other reports, is that the location of the bone injury may be different depending on the relative role of biological risk factors. So we found that cross-country runners were the most likely to sustain bone injury in this study. The second highest was actually basketball players. Basketball players and other athletes that had that really didn't have many of these triad risk factors were more likely to be getting injuries in bones that were much more cortical dense, including the metatarsals, the cuboid, the talus. And as you got to the moderate risk and the high risk category athletes, you actually see more stress fractures in the pelvis, the femoral neck, bones that are thought to have more trabecular rich content, and therefore may be more hormonally sensitive to changes related to biological risk factors. So again, this makes the argument that not all bone stress injuries are created equal, and injuries, particularly involving the pelvis and the femoral neck, do deserve consideration for a DEXA scan and further risk factor assessment to ensure these are not athletes with low energy availability. What we identified in our study with the collegiate athletes has been previously substantiated. Mark's, generated the earliest report in 2001, and what he found was that compared to those with injuries in a cortical-rich location, those with trabecular-rich site of bone injury appeared to have a threefold increased risk for having low bone density when they would receive a DEXA scan to evaluate their bone health compared to those with injuries in bones in the foot or the tibia and fibula. So when we start to think about the ways that we can approach this then for injury prevention, we should really think about using tools such as the female athlete triad risk stratification or relative energy deficiency in sport, red cat, to look for biological risk factors for low bone density. We should think about promoting in athletes adequate energy availability along with appropriate calcium and vitamin D intake, promoting good sleep, and finally promoting sports sampling, particularly in jumping multidirectional sports during that critical window of time around puberty to promote peak bone mass. So again, this triad risk assessment scoring criteria is easy to follow. It can be used to help with clinical decision making on clearing an athlete. We should think a little bit too about calcium and vitamin D, particularly in younger athletes. This was a review that I completed 12 years ago. And essentially what we concluded was that particularly in younger athletes, higher levels of calcium intake, 1,500 milligrams or greater per day, and vitamin D intake may be protective against development of future stress fractures in younger athletes. This was really based on two key studies. The first was by Joan Loppe, where she was giving calcium and vitamin D supplementation to female Navy recruits. And in this 8-week trial of assigning calcium and vitamin D supplementation, there was a 20% reduction in stress fractures. These findings were so significant, the military will offer supplementation to military recruits to reduce their risk for injury to this day. When we looked at other studies, this study comes from Jerry Knives and my collaborator Kristen Ciani at Stanford, and what they identified in a two-year randomized controlled trial where they did a sub-analysis looking at nutrition, they found that higher calcium intake appeared to be protective against developing stress fractures. And in fact, across all different forms of calcium intake, the risk of a future stress fracture was reduced by 62% for every additional cup of milk consumed per day. If that was a medication, that would be a blockbuster and would be heralded as like the anti-osteoporosis drug. So when I counsel athletes on their calcium targets, I'll recommend they meet the guideline for calcium intake, but I'll really advocate that they focus on calcium-rich foods. Because if you think about the components of milk, it's not just a form of calcium, it's also protein, vitamin D, phosphorus, or vitamin D supplemented, phosphorus, and other macronutrients, along with caloric intake that's going to promote stronger bones. Another sub-analysis that we presented in this report was those athletes who consumed less than 800 milligrams of calcium per day had a 6-fold increased risk of stress fracture compared to those who consumed greater than 1,500 milligrams of calcium. I don't necessarily recommend that all athletes target a higher calcium intake level. The clinical concern we have with excessive calcium intake in younger athletes is the risk for kidney stones. In older athletes, higher levels of calcium intake, there are some concerns that may be promoting atherosclerosis. So what we should really try to do is at least ensure that people are meeting their RDA or their Institute of Medicine recommendations for calcium intake from diet. What are these values? Well, I think this is a very board relevant question. What we're dealing with during childhood and young adult, for childhood ages 9 to 18, you should be targeting 1,300 milligrams of calcium intake per day. The needs are higher for those females that are either pregnant or lactating to meet 1,300 milligrams a day. What you'll see though is postmenopausal females, so typically, in that early 50s phase and higher, or men at ages 71 and older are recommended to target 1,200 milligrams a day. And otherwise, during adulthood, we're looking at 1,000 milligrams a day. The upper limits are also presented here, but to recognize that it's hard to overdo it with calcium intake, particularly from the diet, but there does need to be some prudence not to be taking excessive intake. When we look at vitamin D, this is an area where I do think a supplement's reasonable. We cannot assume the bioavailability is high in a lot of our foods or that we'll meet our RDA targets through diet alone. We'll also recognize that these targets are independent of sun exposure. So there really isn't convincing evidence that sun exposure is going to prevent you from developing a low vitamin D serum level. Essentially, what is recommended at this point is targeting 600 international units of vitamin D per day. Recognize that RDA values are based on health. They're not for the general population. They're not based on targets for athletes. So it's not necessarily wrong to recommend athletes to be on a vitamin D supplement and to be considering, even taking 1,000 international units or potentially higher per day, especially if they have a history of bone injury and their vitamin D levels not above 30. Now, another component that we oftentimes overlook, and I'm sure as fellows you're experiencing this, is impaired sleep. And it's important to recognize that sleep has a huge influence on recovery and risk for injury. This one study, which I hope will not be repeated, was done by Ben Sasson in 1994. And what was evaluated was male military recruits that were either forced to sleep standing upright for 6 hours a day, were sleep deprived 62 hours a day, or were allowed to sleep in a normal horizontal position. Changes in bone density and bone turnovers were measured over a 7-day period. What was really surprising was that those that were sleep deprived or forced to sleep vertically, a large portion of them had significant turnover of calcium and hydroxyproline excretion, suggesting rapid loss of bone. And this was associated with a 5% reduction in bone density. This would be the equivalent of going down a full standard deviation of bone density in a 1-week period. So when you think about the phenotype of the driven athlete who you may be concerned about a bone injury, or they may be recovering from a bone injury and looking to cross train, one of the common clinical pearls I'll point to the athlete is to mention this study, and also to advise thinking about focusing more on sleep as opposed to worrying about cross training and impairing bone healing because you're not getting enough sleep to accomplish those aims. The sleep standards have actually been applied, and not to my knowledge in runners, but actually in military, where they did modify their marching, but also introduced minimum sleep requirements. And this was actually able to reduce the risk of a stress fracture compared to historic cohort by 62%. This also resulted in lower grade bone stress injuries and a more adaptive response for those athletes who remained healthy of bone gains. So again, highlighting the importance of promoting good sleep in those that are recovering from a bone injury, or those that have had a bone injury and maybe at a future risk. You know, just continuing to challenge your body with high intensity sport and prolonged endurance athletics may put you at risk for future harm. And then the final thing that I think is really important is thinking about sports sampling, doing ball sports to really promote stronger, more fracture resistant bones. And when this is combined with optimal nutrition at a young age, I think this is one of our best preventative strategies. So in summary, I like to just review that bone health is influenced by a number of factors, including mechanical loading and biological risk factors, largely understood by the low energy availability state and the associated impacts. Endurance athletes, including those involved in the sport of running, appear to be at an increased risk for impaired bone health and injury. We should think about methods to optimize skeletal health by better screening for markers of low energy availability, promoting bone loading activities and sports sampling at an early age, adequate high quality sleep, and then finally promoting good nutrition, including energy availability, calcium, vitamin D. I like to end with this slide. This is my daughter when she was 2. She's now 9. They grow up so fast. And in this picture, this was her first day going to like a sport soccer practice. And so she was a really good sleeper at a young age. She's got her sippy cup of milk there and was really excited to be out with dad just playing soccer. So just remember, sports should be fun. And if we promote just basic lifestyle factors, we can really promote lifelong skeletal health. So with that, I'll thank you for your attention, and I'm happy to take any questions.
Thank you, Dr. Tenforde. That was fantastic. And the time kind of flew by. There was so much to cover. There was a question that was brought up in the chat by Marco. They said the forces on the bones of a smaller runner, for example, 5'2" versus 5'6", are going to be not just absolutely lower, but relatively lower. And on the other hand, a smaller runner is going to take more steps. Have you considered taking that into consideration as to how you interpret bone density studies? So in other words, the taller runner, they were saying, is at a higher risk at the same Z-score than a smaller one.
Yeah, so there are concerns about bone size and relative fracture risk. I think, you know, the more important factor to consider is takeaway from this talk is really looking at bone density, being able to identify what are values that are of clinical concern. And again, those are BMD or BMC Z-scores of below -1.0. Also recognizing that bone density is a proxy for bone strength, but it, you know, again, my fellow boneheads in the research world, we know it's an imperfect science. That's why a lot of these high resolution studies are done. You also bring up a really interesting point, which is step rate. And it has been shown that higher step rates may be associated with a lower risk for stress fractures. That's some of the more recent work by Brian Heiderscheit in college athletes. So when you think about modifiable risk factors, you can also think about other biomechanical factors. There's a lot to cover when we talk about the risk for bone stress injury. But the bigger factor is not necessarily just to think about modifying, you know, non-modifiable risk factors such as someone's height, but more along the lines of what are the activities we should be thinking about doing and how do we interpret a DEXA correctly.
Yeah. Edwin asked if there are adjusted recommendations for daily intake of vitamin D and calcium for athletes with acute stress fractures or healing fractures or surgeries.
So I think it's a really, it's an important question. And what I present are the RDAs, which is like the board answers. What do I do clinically? If I have someone with a low vitamin D status, I supplement the heck out of them. It's safe. I mean, we all learn in medical school ADEC, and so that means it's a fat soluble vitamin. Are you going to overdo it with vitamin D? I've had a few athletes that come in, they're the extremophiles, their values are off the chart. That's not helping their bone density either. Okay, that's just going to lead to like rapid metabolism. So what may come out of the literature and applied sports science may be shooting for a vitamin D level, particularly in athletes with a history of bone injuries closer to the 40 to 50 range. What I do is if an athlete's below 30, I'll just start them on 50,000 IUs of vitamin D3 once a week, 6 to 8 weeks, recheck their value, try to figure out how to get them on a maintenance dose. From a calcium intake, I like to cite that study by Jerry Knives, reminding individuals that calcium supplementation, you know, it's okay if someone truly is lactose intolerant. That's just cruel and unusual to tell them to pound milk. But what we have to understand is that if you can absorb foods that are rich in calcium, they probably have the building blocks and the substrates that are required to improve bone strength. And what I think is really unfortunate is that our athletes are all being bombarded by this multi-billion-dollar a year industry around supplementation, and it's basically trying to outsmart Mother Nature. What is it in this food that I can extract and sell to you in a tablet form? And very similar to exercise as medicine, you know, nutrition is huge. It's going to be more powerful than a number of different pharmaceutical compounds for promoting good bone health. So for calcium intake, to answer that question, they need to at least hit their RDA target. Some will, in female athletes that have lower bone density and persistent amenorrhea, they may even consider targets of 1,200 to 1,500 milligrams. I find that over half of the athletes I see aren't even meeting their RDA targets. So just to review with them, if you're not getting 1 to 2 servings of calcium food in your diet, you're probably low on your calcium intake, and that acute intervention can be very powerful for them to understand what they need to change immediately.
What is the role of sunlight in the vitamin D activation?
So it's a really good question. We know that vitamin D status tends to be lower in athletes that are further away from the equator. We know that there are seasonal variations. You can take individuals in the UK and northern latitudes where you study them in the summer versus in the winter, and their serum vitamin D levels will in fact be lower with less sunlight. The bigger point of this, though, is that we're dealing with more skin cancer, and we should not be falsely assuming that by telling everyone to be outside, getting a lot of UV exposure without sunscreen, that we're somehow promoting good bone health. So what I remind individuals on is that sunlight is maybe necessary for your overall health, but it is not sufficient to promote appropriate vitamin D status. Getting into the weeds too on sunlight, we have to recognize those of darker pigmented skin, those that are higher body mass and older ages. Those are all factors that will also affect your enzymatic conversion to an active form of vitamin D from sunlight. So that's why the sun discussion, I think the bigger thing we should be thinking about is making sure athletes are using sunscreen to to prevent skin cancer, and also considering that in our PPEs to make sure people don't have any atypical nevi or other things that should be seen by dermatology. So in summary, I'm not buying the sun exposure argument for promoting vitamin D status.
I'm going to change the topic a little bit. You mentioned in your talk that it is important to get a menstrual history in your female athletes, and that that needs to be independent of their OCP use. And so for those of you who are doing PPEs, it's important if you do ask if somebody's getting regular periods, you follow that up on what their birth control method is. Do you have a way that you like to kind of script that conversation, Dr. Tenforde?
Yeah, it's, you know, again, a lot of doctors don't feel comfortable asking women about menstrual history, and in particular, like a white dude asking women about their menstrual history. You need to at least preface, why are you asking these questions? And so typically, you know, a lot of people that come to me in clinic, they have questions about their bone health, or we have concerns about whether they may have a bone injury. So what I'll introduce is I'll just say, hey, look, I'm going to ask you about some factors that can influence your bone health and your overall musculoskeletal injury risk. One factor is in female athletes, we like to ask about menstrual periods. You know, what was the age that you had your first period? And then I'll follow up those questions. I'll say, like, have you ever had times where you don't have regular periods? Now, you can also broach the subject by having this as part of your intake form. The PPEs do include aspects of the menstrual history. You know, I've had discussions with a lot of the individuals who started the PPE, and the challenge is that the PPE sometimes needs to be supplemented. It's a starting place for the discussion. But to your earlier point, you know, if a female athlete has been on oral contraceptive pills, which could be for a number of reasons, it could be for contraception, it could be for acne, it could be for other things, you know, the follow-up question comes down to, okay, if you've had irregular menstrual periods, you know, do we understand why? And a lot of these athletes, you know, they'll get to the college stage and people have been signing off on them for years. They've been told they have athletic amenorrhea. This is some type of an adaptive response to exercise, or a lot of almost like the culture around the sport where people feel like if they don't have menstrual periods, that's somehow a sign that they're training well. So what I try to do is I also use that conversation as an opportunity to introduce that, you know, we recognize that information is from historical understanding of what menstrual periods represent, but I like to just present it as this is a female athlete vital sign. And in male athletes, it becomes a more challenging question to ask. You're really asking, and I like to joke about it. I was like, you know, you ever see those like low T commercials? All right, I'm going to ask you some questions about low T. So for women, I ask about their menstrual periods. For guys, I ask other embarrassing questions like morning erection, whether you have libido, whether you have sex drive. And most of the time people are like, oh, okay, now I understand why you're asking this. But it's really important to understand. And sometimes that also leads to some of the corrective strategies where you say, look, you know, even though you don't have a bone injury, I think it's still important to get to the bottom on, you know, why your menstrual periods are irregular. And sometimes you also discover that, you know, women are having menorrhagia, and, you know, and then you learn that they've had anemia, and you're like, okay, well, we should probably address that. That is not going to be good for your overall health, your competition. Like, there's so many aspects that affects for athletes. So it can be really helpful when you introduce those questions. And I don't lead with the questions like, have you ever been told you have an eating disorder? I like to say, well, you know, I'd like to just ask about, you know, ask about menstrual periods, ask about bone injuries. And then I'll go, you know, and I also just want to check in on your eating, and the ways to best phrase that are, you know, do you have a special diet? You know, are there certain foods you like to eat or you don't like to eat? And then sometimes people start to, you can kind of get a sense. They're like, yeah, well, okay, well, I don't know. I'm ovo-lacto vegetarian, and then you're like, okay, well, that's interesting. And, you know, and sometimes your intake form will also include disordered eating disorders. I just put that on there, and sometimes I'll just ask, I'll lead up to that. I'll say, well, you know, this is really common in the sports medicine community. A lot of individuals that sometimes due to their sport, they develop certain behaviors around eating. Have you ever been concerned about disordered eating? And so you'd be surprised the number of athletes when they really understand why you're asking the question, they'll be a little bit more forthcoming. Not always. I've had patients literally lie to my face that I know were hospitalized in the course of medical care. Like it's tough. And it brings up a bigger question for us as sports medicine physicians. Are we doing a good enough job normalizing mental health? And mental health includes anxiety, it includes depression, it includes a lot of the brave women and men during this last Olympic cycle that have been willing to talk about how their mental health has taken a hit due to all the demands of their sport. And I think a lot of the behaviors around eating oftentimes are intertwined with identity for the athlete and lack of control around what's happening with COVID and the inability to compete and do the things that athletes want to do. So I also just try to normalize those feelings, acknowledge them. And if you create that space, you'd be surprised. A lot of athletes are going to be pretty forthcoming about things. And that just creates such a great opportunity for you to help them.
Yeah, and you mentioned kind of how you ask those questions is so important. So a lot of high-level athletes have very restrictive eating patterns that they think are adaptive, that they don't think are pathologic, or they don't I necessarily think they have an eating disorder. So one way that I've found to kind of get a true answer is to ask if they have any restrictions to their diet. And then, like you said, they'll start listing their restrictions, and you just try to keep your eyebrows from going higher and higher with each thing. But that can kind of just create the conversation of why are they doing that? Is there a reason for it? And so it's just creating a space where you can have that dialogue.
Yeah. And then the other thing too is I think there are a lot of athletes that are also being willing to share about their struggles. So I took care of Drew Hunter, where he blogged about me seeing him as an athlete, talked about how we kind of came to the conclusion that he had Red S. Meb Kefletsky talking at ACSM a number of years ago, talking about how he was diagnosed with osteoporosis, fractured his pelvis in the setting of a failure to qualify for the Olympics in 2008, and his long journey back. And then in a lot of female athletes, just a shout out to Molly Huddle and Sarah Slattery, we're putting out a book that's going to be published soon called How She Did It. And it's a story that's really, the goals are to empower young women to understand that a lot of the challenges, a lot of the myths around what needs to be done at younger ages to be successful later on. I think it's going to be a wonderful book, a lot of wonderful women, and then one dude who contributed some stuff on bone health. So I was very honored that they felt I would be helpful. And I just think that can be also very powerful too, for people to be able to have role models to identify with.
I think that's a great note to end on, that there are so many more resources. This is evolving at all times, so stay tuned. I think one thing that you mentioned in the questions is a high risk for stress fractures is a prior stress fracture, so make sure we're asking those questions. Thank you so much for your time and your generosity, Dr. Tenforde. We appreciate it. And just a reminder, we'll be back next week for the topic of anemias. Dr. Melody Hrubes will be speaking. Thank you very much.
Thank you.